never had a C-section birth in the past, today is going to be just really informative. And also I think when we discuss topics like this, it opens up the conversation about choices. I think we often feel like there's only one choice for that sort of birth or one choice for that sort of birth. And hey Jamie, as I always talk to you about, hey in Toronto, hey in Australia, what I always talk to you about is that wherever you are in your birth journey or planning or preferences, there will always be choices to consider. That's what's really important. And that's also what gives us that feeling of control over our birth experience, which is hugely important. Talking about control, when we look back on our birth experience later, feeling like we had some control, that we were informed, we were educated, we were supported with those choices, that is something that will stay with you. So it's really important. We need to get away from thinking that there's just one route. So today is great because this is a great conversation to have. And I've never had a C-section birth. And so I don't know a lot of the conversations that happen around VBACs. But I know from a yoga and birth perspective and positioning perspective that this is something that will always benefit your birth. So I'm really excited to get stuck in today. Hey, so excited for today's talk. I'm from London, UK, 32 weeks so far with previous emergency C-section due to a breech baby. And breech births are coming up today. Somebody else has asked about their VBAC options if a baby is presenting breech as well. So that will be great to discuss that. So I'm really pleased that you're here. So I will let Angie come in now. Make sure you've all got something to drink, you're sat comfortably, maybe you've propped me up somewhere, maybe I'm chatting away in the corner of your room, or maybe you're out walking with me. And I'm going to hand over pretty much to Angie today because this is not for me to answer, this is definitely for Angie. So let me go to, do I go here? Yes. Cool. Coming in. So what I'll do is I'll answer the ones that have come in on here first, and then I shall go to the ones that are below as well. Okay?
Hello, how are you
doing? Good morning. It's lovely to see you. Yeah, really well, thanks. How are you?
Yeah, not too bad. Quite enjoying the sunshine that's coming through my window, actually. It's looking like a lovely day.
Nice. It changes everything, doesn't it?
It does. It makes such a difference.
And you're obviously off work today, so that's nice. Thank you for being here.
I've got annual leave this week, which I'm so excited for. It's so nice to have a week off, but I've got training to do this week, so I need a week off, but it's not
really a full week off, but oh well, thank you for being here. And I know you and I have been trying to find a spot for a while, so I really appreciate it. It's going to be so helpful. And I know that you're really passionate about VBACs. And giving women information about it.
Absolutely, and it was part of my master's project. So I did crazily when I was pregnant with my daughter. I signed up for a master's module.
Oh my goodness!
I'd achieved that basically, and didn't quite get it done before she arrived. So spent basically the first 3 months of motherhood getting my mum round to sit on the sofa with my daughter.
Wow, that's amazing that you did that.
I'd be in my breastfeeding basically. So I'd go down breastfeed, then come back upstairs and work more on my masters, and it was all about VBAC basically. And basically presenting choice to women. It's not about telling women they have to have a VBAC. It's not about telling them they need a cesarean birth, but it's about presenting the choices in a way that they can understand, and so that they can make choices which are right for them. And I'm hugely passionate for that, because a lot of obstetrics comes from the Royal College of Obstetricians and Gynecologists who only look at the risky things. And the problem is
that's their job, isn't it, to look at risk factors and to medicalise, because that's why they're trained. That's how they're trained.
And that's all they see. They only see the really high risk things that don't necessarily go as straightforward or as planned. And the problem with that is then they take a very narrow-minded view of what actually women can have or can achieve. And of course that then narrows down the choices that are presented to women sometimes. And so when you actually break apart all the research that's actually as part of their Green Top guidelines, so they have guidelines basically, and only about 12% of their guidelines are based on evidence at all.
Wow.
That means 88% of their guidelines are based on expert opinion. So what they've seen over the years, and of course you've also got to think about the people who go into these sort of clinical guidelines sort of discussions, they tend to be consultants, they tend to be people who have worked through their careers, and you've got to think about how birth has really changed in the last 20, 30 years.
And yeah, and how we're
Especially
now
with-
seeing birth, you know, it's, and as you said earlier about whether these consultants and obstetrics, that, you know, if they've seen birth unfold in its normal state, then obviously more able to understand what birth can look like from all angles. But if you've only ever treated and seen birth as a medical risk, then it's very difficult, isn't it, to understand from other people's perspective why there aren't always going to be those risks, or there are other options. But that's why we've got people like you that are here to spread the word. It's really important though, isn't it? Because
it is.
I know that VBACs only in recent years, well, I feel like I've been hearing more recently that the options are far more open now. It was always assumed, wasn't it, you have a C-section birth and then you're already kind of automatically limited with your choices.
And that's because, you know, that came from the theory of Cragen's theory, basically.
And that you to explain, yeah, please do, because there might be people watching who don't understand why would there be any problem with having a vaginal birth after cesarean. And there might be people here that are saying that, oh, I would absolutely not have a vaginal birth after a C-section. So do explain why it's even a thing.
So basically, when cesareans first became a thing, really, it used to be a classical cesarean birth. So that's where you are having a cesarean top to bottom. Right. So instead of the lower segment just above the bikini line, that's the most common form of a cesarean birth these days, top to bottom increases the chance for uterine rupture very significantly. Right. And that's because it's going in line with the longitudinal muscles. And if you think about physiology of labour, when our uterus contracts, it draws up the muscles. And of course, it used to go in line that if you had a classical top to bottom, that's where the increase in rupture significantly increased.
So that would be the scar tissue from the healing would prevent the uterus contracting in that way.
Yeah, so basically it interferes with the contraction process. So anyone with a classical cesarean birth, and these are typically done if you're really premature, so usually under 26 weeks, and that's because the lower part of the uterus hasn't formed by that stage, so hence the classical birth. Or if you've got placental location issues, but you would have the classic incision that you can see top to bottom of the abdomen. It's really uncommon in this country. I've only ever seen a handful of classical cesareans done these days. And the last one that I saw was probably in my second year of student training. She'd had a classical first time round, sadly had a stillbirth. She'd had a massive placental previa that bled massively. And so she had a second classical cesarean birth because of her previous classical cesarean. I've not seen one since, I'm going to be really honest, because we just don't
the standard practice now is, as you say, your horizontal line incision just above the bikini line.
Absolutely. It's what we call a lower segment incision. So lower segment of the uterus, literally above your knicker line. That tends to be what probably 99.9% of all cesareans these days, especially in the Western world as well. Talking sort of in America, the UK, and most places do that.
How many years? Do you know for how long that's been standard practice, or for quite a substantial amount of time?
Yeah, quite substantial. I'd probably say sort of the 80s. Even earlier than that, it's probably been pioneered, but 80s is where it started really taking off, and that's where it's become really commonplace for most women to have had a lower segment incision.
Wow. And is that because they are aware of how that would impact a subsequent pregnancy and birth?
Yeah, so it actually leads to better healing and much quicker recovery. Again, if you're doing a top to bottom sort of incision, actually that takes so long for those muscles to recover. And you've also got to think about the wider society, the wider picture of healing as well, in terms of the abdominal muscles, the abdominal sheath. You know, you've got to think about the other sort of implications that a classical cesarean birth can have compared to a lower segment. So a lower segment, it heals much quicker. It's just a much quicker recovery, a much better recovery, and better chance for future pregnancies as well, of having less complications really in general.
Cool.
So because of that, actually the chance of uterine rupture by the RCOG guidance is 1 in 200. So a uterine rupture is more likely to happen if you've had less than a 12-month interval. So if you've been pregnant within 12 months of having the cesarean birth, and that's because actually you've got to think about all the layers of the uterus that have to heal really, really well in order to prevent a uterine rupture.
Yeah.
So it takes a long time, and that's why they recommend no earlier than an 18-month gap, ideally, between pregnancies. Don't get me wrong, there are women who have less than a 12-month interval, and one of the women I supported in her first hypnobirthing course, and then again in her second pregnancy, she had a less than 12-month interval and had a home birth in December, so she had a Homebac.
Amazing.
Medical advice, but she did it, and it was an amazing birth for her.
That's so encouraging.
With 2 under 2, it's really challenging for her to sit down and write her birth, but she has promised at some point I can share it. But
you'll have to.
We do have women who have less than a 12-month interval. It just means that the risks increase, not just for uterine rupture, but for there's an increased chance that the placenta will embed into that scar tissue as it's healing. So that increases the risk of things like stillbirth, miscarriage, and postpartum hemorrhage as well. So again, if you can leave 18 months or more between pregnancies, you're more likely to have a successful pregnancy in itself. Also more likely to go on and have a successful vaginal birth, but you're less likely to have those complications that we get really, really worried about as midwives and as doctors. And one of our biggest, and this is the real big risk side of things, is women who've had previous cesarean births. The more that you have as well, there's something called placenta previa, which is where the placenta embeds over the scar tissue and over the cervix, and it is increasing every year in this country because of our increasing cesarean birth rate, that women are dying from this in this country. And that's still a really rare risk. It's 1 in 10,000. So we're not talking massive amounts in this country, but it's a massive mortality factor in the US where they are doubling their cesarean birth. And it's not to say that we shouldn't be doing cesarean births. They are life-saving procedures.
Of course, God, we're so lucky to have them, aren't we?
Absolutely, but they need to be done with caution, and if we can prevent that in the first place, that's the great thing. You know, actually, if you can prevent that cesarean in the first place, that'd be great.
And I know that midwives want you to have that if you've planned that vaginal birth, because it's the way, you know, abdominal births are big abdominal surgeries as well, aren't they? So the healing is shorter and easier with a vaginal birth. So everybody wants that for the women who want that. But as you say, we do have a high cesarean rate, and I had no idea about that. So it's good to understand the risks that come, you know, sometimes, which I know is tiny, as you're saying. But it's still and the thing is we're noticing more and more as women, as midwives in the hospitals, is that we're having lots of longer term stay patients. So if you have these placental anomalies, then what we recommend is that actually you stay in the hospital for the majority of your pregnancy. And the reason being, if you suddenly bled from that placenta previa, or something started happening, you're literally, you know, down the corridor from theatre, basically. So we have lots of women who have got a placenta previa, especially if they bleed. And the earliest one I've ever known to bleed from was 22 weeks of pregnancy with 4 previous cesarean births, 4 previous children at home. She was in from 24 weeks until she was 35 weeks over Christmas, and that's a long time to be away from your children.
And especially now with COVID as well, we've got long-term patients who can't see their young children at the moment, and that's heartbreaking.
And this is again placenta previa that has then led to a bleed. And placenta previa, so you said, as you said, just to clarify for people, it's where the placenta lays over the cervix so they can't vaginally birth because the placenta's blocking. But because of previous C-section, is that because the scar is sort of a place that the placenta just naturally embeds to? It's being drawn into that scar tissue and then it kind of stays there, or?
We don't know why, but somewhere along the lines, I guess, with any sort of scar tissue, and it can happen with women who've had ERPC, so after a miscarriage, sometimes women are after surgery as well. So sometimes it's not just a previous cesarean birth, it's uterine surgery in itself. And I guess it's just wherever that egg and that embryo has implanted and then embedded those placental cells as part of those really early fertilization. Then actually that's just where it's gone more than anything. But we know that it increases, especially with previous cesarean births. And the more women who have cesareans and multiple cesareans, the more chance of it happening. So It's less likely after your first. It's not impossible, and certainly we do have the women who've only had one previous cesarean who end up long-term staying with us.
Yeah.
But the more cesareans a woman has, the higher the chances of complications in future pregnancy. So, and the higher the chances.
Interesting already. I'm like, so much information. It's really helpful.
But yeah, that's the whole reason behind trying to encourage, wherever possible, as long as it's safe, a vaginal birth for women.
Definitely.
So
yeah,
the other benefits of a VBAC aren't just in terms of lower chance of future pregnancy complications. So if you're planning on future babies, you know, you're not planning that this is going to be your last baby, you know, lower chance of miscarriage, lower chance of stillbirth, lower chance of uterine rupture. For your gynecological perspective, your lower chance of having endometriosis.
wow.
So endometriosis also increases with cesarean births. And
really?
again,
I had no idea.
Yeah, and that's again one of those things that you don't necessarily know unless you have a read into things, because it isn't always discussed with women about these things. And probably the one biggest thing I get from women is, actually, I had a cesarean last time. No one told me that I would have 6 or 7 recurrent miscarriages after having that, you know, cesarean birth. And we need more research into it. Don't get me wrong, we really do. But you do tend to find that either women have more trouble conceiving, and I guess because of the scar tissue, sometimes the fetus is less likely to grow and birth because of the scar tissue. So I do find that secondary infertility tends to be higher in women who have had a cesarean birth as well.
Wow.
But yeah, other benefits of a VBAC, so better chance of recovery, better chance of the gut microbiome for the baby being better. So when they're born vaginally, they take in all this really good bacteria and they throw it on the way out. And the whole reason why they come out next to your bottom is to get that good bacteria in their gut. And when they're born through a cesarean birth, antibiotics are given to lower the chance of antibiotics, but it's a really sterile environment. And the higher the gut bacteria count within the baby, the lower chance of asthma, of obesity, and it's really new at this moment in time, but allergies as well. So babies who are born by an elective cesarean birth, so a planned cesarean birth, are the ones with the least amount of good bacteria in their gut.
And why is that different then, out of interest?
Compared to an emergency birth?
Yeah, so why would their gut flora be different?
So an emergency birth, usually waters will have gone, or they've started that process where actually they start swallowing some of that mucus even before they come through the birth canal. So they've started that process early, and they're looking into it in Germany at the moment, where they actually start women who are going to have a planned cesarean birth. They actually start their labour off, then the really early on. So they don't go through the whole of labour, they don't go through the whole of labour and birth, but they've begun that process so that actually then that baby's getting good bacteria count, but also to try and lower the incidence of complications for mums as well, because again, babies are less likely to go to special care as well if they're a bit more ready with their lungs. Which is one of the common problems of a repeat cesarean birth. Is a planned cesarean birth, they have about a 6% chance of going to special care baby unit with breathing problems, where they just maybe weren't quite ready, where they haven't developed that surfactant quite on their lungs yet, and we've brought them into the world a lot earlier. Whereas again, if we put women through labour a little bit, just a small amount, then stop that and then put them through a cesarean birth, the theory is that will lower the chance of neonatal care admissions and also improve the bacteria in the baby's gut. But it's in its early days of research.
That's so interesting. And the microbiome is something that I'm so interested in. I want to study more about how, oh my God, how hugely important it is for babies to collect that somehow, some way during their birth, for them, for our future as well, isn't it? It's responsible for how we evolve and how we birth our babies as well, and everything in that bacteria is so powerful. So that's good for women to know also, that is another reason to consider VBAC if they didn't have that vaginal birth first time round. There's so many things to consider.
And the thing with the microbiome is it's only 20 years old. 1999 is the first study that really came out about it. So we are really early into research. Women's health really irritates me anyway, in the fact that, year on year, Viagra research has more money ploughed into it than we've had as women and in the last 25 years. And actually, a lot of what we do in maternity and in obstetrics and gynecology is based on expert opinion, but purely because we haven't actually had the money ploughed into research projects. And the things you've got to think about, what we research tends to be based on pharmaceutical companies and what they want to do.
Absolutely.
So most of the funding goes into developing drugs for reducing postpartum hemorrhage rates. They go into medications to be able to help with inducing labour. What we tend not to get so much research money for is actually, let's look at populations and let's see what naturally occurs. You know, let's put some money into raspberry leaf tea, you know, let's put some money into acupuncture or other things.
Or seeing
because
birth as it is in its normal state. I would love for there to be more awareness of just birth as it normally unfolds. Let's look at that. Let's look at free birth just to see it unfold. Let's just look at what happens when we don't get involved so much, because the studies, can you imagine if what we'd learn from just letting things be, if everything's safe and fine, let's just see. But we want to get involved, don't we, so much, because it's medical, and you know there are pharmaceutical companies involved, and so it's good that we can have these topics, these conversations, though, because there are so many things like still untouched, like microbiome. It's still so early on, but there are people out there who are wanting to learn more and share it. So we're learning all the time at the moment. I feel like we're in a really good stage of
actually, you know, medical, you know, births and medical technology advancing is really good in itself, you know, because actually we are lucky to have money being ploughed into some of these things, which is amazing. Actually, you look at our postpartum hemorrhage rates, I'm going to say that they're starting to increase with the induction rate, but in the last 20-30 years, up until the last decade, up until about 2010, actually our postpartum hemorrhage rates for all women, whether they had a cesarean or a vaginal birth, decreased because the impact of giving the injection for the placenta, for example. That's now changing massively because of our induction rates and because of our medical rates of obesity going up as well. We know that women who have a large BMI over 40 are much more likely to suffer with a postpartum hemorrhage. So there's a lot of things going on with the medical world that actually we need to start looking into a little bit more. But up until 2010, we massively dropped postpartum hemorrhage rates thanks to medical technology and thanks to pharmaceutical companies. And you know, we are lucky to have
that as well. Well, that's interesting, as you say, about the high BMI rate and postpartum hemorrhage rate. So again, a lot of it is lifestyle, isn't it? And there's so many layers and elements to it. But I completely agree. We have to remember how, you know, here in our culture, in our country, how lucky we've got the option to have medical care, really high end medical care, as and when we need it, and we have the option to have a vaginal birth after C-section, have a home birth after C-section. So we are so lucky to have those options, and I think it's just knowing what they are. That's sometimes a block for women and families, is just knowing that there is another route or whatever. And we've got so many things to discuss, because of the C-section rate is high here in the UK. We have a high C-section rate. There are women who want to ask about their options going forward. Are you happy for me to ask you some questions?
Yeah, carry on.
We've all learned so much, because you've given us so much information. It's so interesting, and I can tell how passionate you are about it. And have you attended any? Did you say you have attended home births after C-section, HBACs, Homebirths?
I haven't. So I am one of those midwives that is transferred for every home birth that I've ever had. I went out to community in April and I still transferred, the only woman that I had since qualifying. So I've been in the unit for 8 years. Right. As a student, I only saw 4 home births. I'm very passionate for home births, and it's something I've discussed with women, but I just haven't had that opportunity. The times I got called out while I was in community was always to the unit to cover the unit because they were short-staffed or because they were really busy. And the only home birth I got, literally just as I was finishing, we did transfer in second stage for a very prolonged pushing stage. But apart from that,
to see that full. But you know the benefits, and of course.
I do, and it's something I think all women should have the opportunity to explore. Whether it's right for them is their choice. But we've got loads of benefits with home birth that I'm very passionate for.
And I like to see home birth as just an option that you're giving yourself on the day. It doesn't mean you have to stick to it. It doesn't mean you have to stay at home. If you don't want to stay at home, you can go in. But it's you can't change that round. If you decide you want to stay at home now because you're so comfortable, you can't suddenly expect the home birth team to come because they've got. So I always say, if you're thinking about it, have it opt in and then change your mind. I think that keeps the pressure off as well.
Absolutely. And I think the thing is, with continuity of care, what might start happening is actually you won't have to opt in. So what they found with one-to-one births up in sort of the Wirralls and everything else before they got dismantled by the CCG and stuff, what they found is actually what they would do is they would go out and assess women in early labour.
Oh, okay.
Because they were their own midwives and their own team. So they would assess them in early labour. And then what they would do is put the decision making to the woman's hand. Do you want to go in? Do you want to stay here? What do you want to do? And if you want to stay here, we've got everything in our car. So we'll come and see what you want to do, really. Or because you're in early labour, we'll come back later on and then we'll make a plan with you. So yes, that's the gold standard. And if you had an independent midwife, this would be what you would be doing. You wouldn't even have to opt in for home birth. It would just be decide where you want to go on the day. But in NHS, in most of the country, continuity is still not completely taken off because of COVID and other things. So always ask, if you're considering a home birth, have a home birth assessment. Now with VBAC, it will be against medical advice.
Ah, okay.
And I'm going to put that out there because the RCOG and the NICE guidelines say that you should be within an obstetric unit to birth. And the reason being, if you had a uterine rupture, so if you had that 1 in 200 chance, and you've got 199 chance of not having one, then they'd like you to be within half an hour of a theatre.
Okay.
So that way they could quickly have a baby's born, basically, before the point of uterine rupture causing any long-term harm. So that came from lots of studies. The earliest one was 2004, and there were about 12,000 births that they looked at home births, and about 1,000 of them were VBACs. And in that VBAC cohort in 2004 in America, okay, so that's where the study came from, they found that there were 5 neonatal deaths in that cohort. 1 had gestational diabetes, 1 had preeclampsia, 1 was twins, and 1 was breech. Okay. So they were all the ones delivering at home. So that was only 1 really in 1,000 with no other complications. So it's also thinking about the wider picture of what else is going on in medical history as to whether or not a home birth might be more suitable for you or not. The other studies that they include in the, and these are all available, so if you go to the Green Top guideline on the RCOG, look down to the references and have a look at the home birth references, then you'll be able to actually read these studies yourself to make an informed decision, really. They also looked at the Amish community. The Amish community had a 94% chance of a birth after cesarean, a vaginal birth, and only a 5% transfer rate, either in their standalone birth centre, 20 minutes from consultants and obstetrics, or from doing it at home.
I find that so interesting.
Is, and it just shows that I mean, vaginal birth at home is more likely to be successful, and the very latest study shows that women who plan a home VBAC, a home back, are 39% more likely to have a successful VBAC than going into an obstetric unit. And that's probably because actually you're more comfortable, you're in your own surroundings, you're in your own environment. And that latest study that's come from Canada looked at 4,500 births. 561 of them were people having VBACs at home, and the other were just having VBACs in a hospital, basically. We found a significant increase in successful VBAC at home, and there was no morbidity or mortality difference between the groups. So there was no, difference between the uterine ruptures. There was no difference between So the latest study shows that actually it's probably just as safe. And because we're starting to understand the ins and outs of VBAC a lot more, so we're actually really cautious about the signs and symptoms of rupture. We're very cautious about we're more likely to transfer early as well. And all of the research that's been done on home birth after cesarean has found that women are more likely to be transferred as well. So they have, in first-time mums, you've got about a 45% chance of transfer from home birth. That's about the sort of birthplace study. You're about 50 to 60% chance if this is your first vaginal birth after a cesarean, and it's not, your second, third, fourth, plus since you've had a cesarean birth. then you're about 50 to 60% chance of transferring. That's because we are a lot more cautious and we transfer in a lot earlier.
Do you think that's because of acting sooner than you would, because you know it's a VBAC mum and you know that their uterine rupture risk is there, so the home birth midwives will act and get them to safety? Yeah,
absolutely. So I think we're more cautious. So I think that's the other thing, is care plans are made very early on. And in some parts of the country, you can have a midwife-led centre birth.
Yeah.
No, not in all parts of the country. I've been desperately trying for a while where I am, but it's not going too well. But in the Serenity Birthing Centre in Birmingham, for example, Cambridge, the Rosie, and there are quite a few others up and down the country. I think Yorkshire, some places in Scotland.
Yeah.
They will still encourage you to birth in an obstetric unit, but they will support you if you've decided that you don't want continuous monitoring, you don't want to be in an obstetric unit with a cannula, you just want a midwife-led centre birth. They can put these plans of care in for you well in advance, either with the consultant midwives, with the head of, delivery suite, or maternity services, whoever's in your local area. And they'll put a really good complex care plan where they'll say, right, if X happens, what will we do? If Y happens, what would you like to happen then? So that way there's no surprises on the day. You've had this discussion and you haven't got a midwife coming in who's going, but we advise that you have to have this, and actually you've gone, actually I've made this decision in pregnancy, I don't want that. And then it means
it's like like an ideal birth preferences plan, but for your specific needs and care.
Absolutely. And a long list of plans that if X happened, meconium happened, would you change your mind? Would you like whatever it is? And we'll go through all the risks antenatally when actually the stress isn't there. So there are some places that do help support you with that. And the Serenity boasts about a 95% chance of a successful VBAC in theirs when they audit their results. Again, it's not with the guidelines, it's on an individualised care plan basis, but they have a really high chance of a successful vaginal birth. And as much as the guidelines nationally say it's about a 75% chance of having a successful VBAC, many of the maternity units up and down the country aren't even hitting 50% in an obstetric unit. So it's worth also asking, what are the rates of successful VBAC within your unit? And then just start exploring why that might be the case. Is it because of the continuous monitoring? Is it because the guideline recommends that you have an epidural? Is it because of maybe that sort of innate physiology not being supported?
I think we underestimate, again, the impact of our environment on birth, don't we? Because, again, I think that shows, doesn't it, when we're in a medical environment, what that does to our birth, what that does to our feeling about our birth, especially if we've had a previous medical birth, so a C-section birth in the past, and then we're back in a more medical environment second time round. It may, that could be something to really consider. How does that environment make you feel? For some people, that makes them feel really safe because it's a place of safety. For other people, it can bring up a lot of triggers of their previous experience or anxiety, and that will affect your birth and how that unfolds. So, as you say, it has to come from your unique, your feelings about this, and getting a care package in place that is looking at you as a person rather than the general public who are having a VBAC. Absolutely.
And it's about also trying to tailor your environment as well. So if you actually do feel more comfortable in hospital, can you shut the blinds? Can you turn down the light? Take in your own music box, take your own pillows, the things that smell of home, the things that are going to really help you feel more comfortable. And getting your partner on board is a real advocate for you as well, getting him into a hypnobirthing program or something where he's going to feel comfortable to say, I'm not happy with what you're saying to me. Actually, she has said that she wants this. So that way you've got someone who can stand up for you in these environments as well, when there might be a normal ward round. If you don't want people in the room, saying that well in advance, putting that in your care birth plan so you haven't got 5 people traipsing in the door at 9 o'clock because it's the doctor's handover. If there's fresh eyes, which is something that's very common at the moment. Every hour you have the monitoring, if you're on the monitors, reviewed by a second person. Well, that is whoever's around. It's a new person every hour that, again, disturbs that birth physiology. And I wish that was different. And it is if you've got lots of technology within hospitals, but not every hospital has got the ability to watch those monitors on desks, sadly, because funding. But yes, there are lots of things that can impact on your birth physiology in a hospital that you can change and you can adapt if you're planning on a hospital birth.
And if you decide to opt in for a home birth after cesarean, one of those benefits is also the continuity of care, isn't it? That you are likely to have had built up a good relationship with your home birth midwives, or at least have met them once or twice before, and it feels like a really intimate environment with you, which is so conducive for your labour. So that's something I'm sure that is so beneficial for vaginal births at home after a C-section. Also, I wanted to ask you, you said that having a home birth after C-section would go against medical advice because they want you to be half an hour near to a obstetric unit. Would that then change if your home was within half an hour of the hospital? No, it's just a standard rule.
Yeah, absolutely. And you've also got to think about our ambulance service. So you're looking at 10 or 15 minutes waiting for an ambulance, then you've got the journey in.
Okay.
It will always be advised until we have a lot more conclusive research. I know the latest evidence shows that it is just as safe a choice, but it's only 4,000 people and it's the latest one, you know, compared to the previous one. So half an hour is the recommendation. That's why they recommend birthing in an obstetric unit, but also because we don't continuously monitor at home.
No, yeah.
This is a whole other debate in itself. And so it's one that I could be here all day talking about monitoring, but I'll try and keep it short and sweet. So when I did my master's project in 2019 and submitted it, the NICE guidelines came out and said there is no evidence to continuously monitor, nor any evidence to routinely cannulate women. 2 weeks later, the RCOG got involved and said, we cannot recommend this. Whilst there is no evidence to support this recommendation, we need this recommendation in. So as a result, offering continuous monitoring is back in the NICE guidelines for birth after cesarean. So the research that supports that comes from category C and D evidence, which is really poor evidence. And it was based on women who had uterine ruptures.
Yeah.
It's not based on all women choosing VBAC. It's not based on all women, you know, choosing a birth after cesarean birth. It's based on the very small proportion of women who had uterine ruptures. So if we take the 1 in 200 chance of a uterine rupture, and I'm just going to increase it to 5 in 1,000 here because it's the easiest way of being able to see clearly the statistics. Otherwise, it makes it difficult to sort of chop women in half, basically. So 5 in 1,000 women from the RCOG statistics, and if you look at the statistics overall, actually a lot of studies say it's a lot less than that, but we'll take the 1 in 200. So 5 in 1,000. And out of those 5 in 1,000, 3 of them will have abnormalities on their CTG before the uterus ruptures.
Right, okay.
So we're monitoring 997 women continuously on the pretense that we could potentially intervene in 3 of those.
Yeah.
A very, very lot of intervention for very small benefit. And the problem is so it's about 60% of all uterine ruptures had abnormalities on the CTG prior to the uterine rupture happening. But the problem with CTGs is once you're on it, it increases the chance of interventions. And I'm saying this, I've got to be really careful because I'm a fetal surveillance midwife, so I do a lot of monitoring things. But basically, when we put the CTGs on, the moment we see any slight change, any slight difference, we have to continue that monitoring, and we have to act upon what that monitoring has given us. And we know that CTGs came in with absolutely no evidence, and we are still learning in 2021 from 1970 when they started becoming more routine, and we are still getting it wrong at times, and we are getting it right at other times. They are not conclusive. But the moment we see something, we have to do something. And the problem is when we have to do something, that usually leads to breaking waters, or putting clips on babies' heads, or changing positions that maybe a woman wouldn't naturally get into, or recommending an epidural because then we can monitor the baby easier. I'm saying this with a very pinch of salt because I know it shouldn't happen, but I know that this is what obstetrics looks like in the 21st century.
And I wanted to say, obviously, with all of this stuff, obviously everything is, if she says no, I'm not doing that, then that has to be obviously it. So what then? Because for you in your position, that's difficult because that's your advice, that's what you're told to do. If she says I'm not doing that, I don't want that monitor on me, then that's also, that's her choice, isn't it? That's her right, because we know it's an intervention. That's where it gets tricky in the birth room, when she says no, then she feels that she has to say yes because she's feeling influenced by the dangers and the risks and the machinery, and it's so difficult. And all of this because of this, as you say, research that didn't actually come from back in from the very beginning of monitoring, we don't really know how that's become a standard practice.
Yeah, absolutely. And there are reasons for continuous monitoring.
Of course.
If you were having an induction, if there was meconium-like, or if you had reduced fetal movements, you know.
Yeah, of course. It's, yeah, again, great that we can detect, isn't it? It's great we can detect it.
Yeah.
But if we're saying it's, yeah.
Just for a VBAC and no other risk factors, no other complications, then you're more likely to end up with the forceps, the von 2s, the cesarean birth, and we know that. You know, we know that, you know, CTGs, continuous monitoring, increases the chance significantly of you having a von 2s or forceps, having an induction of labour, having your labour augmented with the hormone drip.
Yeah.
Increased chance of fetal distress in itself from that hormone drip itself, and then an increased chance of cesarean birth. So, you know, because also you're less likely to be mobile, there are wireless monitors. So if actually continuous monitoring is something you want because it makes you feel more comfortable, it makes you feel safer, and that's fine. And some women do genuinely.
Some people find it really comforting, right? So
they do. But there are wireless monitors that you can get in the pool with, that are waterproof, that you can be upright and mobile with. So there are ways around it about supporting it, but it's being informed antenatally and to be able to make that decision antenatally to go, do I want continuous monitoring? And if I don't, I want to start putting these things in place, because the moment you walk through those hospital doors, if hospital feels the safest for you, they will recommend that routinely. And if you've got that care plan in place, again, you've had that discussion antenatally, you've had that risk and benefits, and have a look into all the research that supports the RCOG really poor evidence recommendation about continuous monitoring, because actually that will give you more of an informed choice to go, is continuous monitoring something I want? And if it's not, then I want to be supported in my decision to intermittently auscultate with, you know, a sonocode. I mean, you can free birth and you can have no monitoring at all. I wouldn't recommend that, and I would never recommend that.
Because I think we need to remember it's they're there for a purpose, but we need to understand the repercussions of once you intervene, like you say, but also birth partners, because if she's got her wishes clear, you know, then we need to, you know, birth partners need to advocate for when she can't, when she's lost her voice a little bit, when she's trying to focus on her contractions, or when she's then confused by all these recommendations in that moment. But yeah, my God, so much to think about.
Roll on more than one person in the birth room for, you know, I would love to see doulas back in the room, because I think they're great advocates for women. They really do. Doulas, they really stand up for women.
Yeah. Wow. We need to talk more.
I could go for a lot longer about these things, but I have to be really careful with what I say. But there are reasons for CTGs, but VBAC on its own accord, there is very, very, very little evidence. And if it's something you're going to consider, talk about it with your midwife antenatally. Get an individualised care plan, because you don't want this argument when you're going into labour.
You don't want to be thinking about it in labour, and you don't want to be confused as well. I think that's you're already very, very heightened, and everything's, when labour's happening, it's very intense, it's very full on, and to then be thrown a curveball of, well, we would recommend this, and all. I mean, I know there have been people I've heard messages of people being really pressured, really pressured to do something that they never ever wanted to happen. But when you're in that state, it can be very easy to just forget all of those things you wanted or didn't want, and be influenced, because it's your baby. We're talking about your unborn baby. You'll do anything to make sure that they're safe.
Yeah, and the problem is as much as we're not meant to coerce as nurses, midwives, doctors in any way, sense or form, maternity is the biggest area of litigation, and we are bound not only by our guidelines to say that we can't do stuff, but our guidelines say that we have to recommend continuous monitoring. And if I don't recommend that strongly enough and something happens to your baby, it's my head on the line.
It's your job on the line.
My livelihood, my house, my everything. I hate that. I hate that this is the defensive practice that we are.
But it is the reality.
Yeah, and actually, if women had stood up and said, no, I will take you to the NMC if you make me do this, fine, stand back. You've made your voice very clear.
Don't you think when don't you think, I talked a lot about obviously about fear of childbirth, but don't you think fear goes in both ways? It's not just fear of childbirth, it's fear for you midwives. You are obviously, you have to protect your jobs, you have to protect your position and the women. That is your job, and so you're also fearing that something does go wrong, and you're responsible. So then you have to act with more intervention than you probably want to. You have to act because that's what your job is. So it goes both ways. It's everybody is at some point feeling fearful, and it does get in the way a lot. Sometimes it saves the day that there is fear, because we step in and we save. Very difficult, I understand, for you from your perspective as a midwife, and you care so much about physiological birth, but there are so many things preventing you from being, you know, how you want to be. And
absolutely,
it's so hard. It's really difficult.
Over the years, you know, we've been completely demonised as midwives by the press, massively. Normal birth and physiological birth. I think most of us are terrified of speaking up for women now, because we've just been beaten down with a brush for a very long time. And
that's so sad.
That's the hard thing about midwifery, and we don't always get it right, and we're not perfect. We don't know women's bodies inside and out because of research not being good enough, and also because you're an individual woman. You know, you're not a number, you're not a statistic in a research paper. You are you with your own unique background, and we don't have that crystal ball yet to be able to say this is what's going to happen if you follow route B, or, you know, we'll know exactly what happens with route B, and it's really challenging. But I think obstetrics and maternity have become more challenging as time has gone on, not because women know more, but because of the litigation side of things. And I think that made it very challenging for us as midwives to advocate. And we can see that in the PTSD rates that are increasing year on year. And I hate that. But
there's so much blame game going on, isn't there? No one wants to be the it's just such a sensitive part of our care in hospital maternity. It's so full of emotion, full of potential trauma. Gosh, so much is involved, and it's creating this terrifying feeling of repercussion if something doesn't go exactly as you were told to do it as a midwife. I can't even imagine, because I'm not one, and you know, I'm here blessed to be able to offer advice from a completely I don't have guidelines. I don't have somebody telling me what I'm allowed to or not allowed to say. I'm not giving medical advice, I'm just sharing. Whereas for you, it's not quite the same, and I get it. But we're so lucky to have people like you, midwives like you, and loads of others. God, I think midwives are amazing, who care so much.
Absolutely, and we do try. So
of course you do, and you bridge the gap for us
between the next decade. Things will go round in a swing again, I'm sure. So that tends to be
keep doing what you're doing, because we need all of you midwives. We need you to still be with us and help us to have the births that we want. Should we do some questions, Angie?
Yeah, let's go for it.
Oh God, do you know what though? I'd be surprised if not many of them have been answered organically, because you've given us so much information today. Thank you. Okay, so am I more at risk of an emergency C-section the second time if I've had one before? So what is the risk for that then?
So the research that has come out of lots of things show that women who've had planned cesarean births are more likely to have a successful VBAC. But it depends on what the reason for the emergency cesarean was. So out of all the categories of emergency cesarean, the one that was least likely to have a successful vaginal birth were the women who had failed inductions with fetal distress. So if you had an induction previously and you go overdue and then you're induced again, then that's where the increased risk comes in. And we know that women who have overdue babies sometimes go on to have lots of overdue babies, and that's, well, I'm not going to talk about due dates because I'll be here for
that's a whole other hour conversation.
Yeah, that's another issue. But we know that because some women just have naturally longer pregnancies. And the problem with VBAC is stillbirth increases after about 41 to 42 weeks with a previous cesarean birth. So that tends to be when most hospitals will guide their cut-off is about term plus 7 to term plus 10, 12-ish. Well, they actually would recommend an induction for you at this stage. The inductions are slightly different with a VBAC. So they tend to be with a catheter, so a little balloon that goes through the cervix, because using pessaries or gel with prostaglandins significantly increase the chance of uterine rupture. Breaking waters doesn't necessarily make any difference in terms of uterine rupture, but the moment the hormone drip starts, it doubles the chance. So it goes from 1 in 200 to about 1 in 100 chance of a uterine rupture. So again,
and that's because of the intensity of the contractions, right, Angie? Because they're so strong. So you're pushing that uterus even further.
Absolutely, and also because induction carries a naturally higher chance of
Yes.
cesarean or spontaneous or
Anyway.
forceps birth. So yeah, there's lots of reasons for it in general, and because lots of women who will have an induction will have an epidural, and having an epidural can mask some of the signs and symptoms of a uterine rupture.
So uterine rupture, symptoms of that from if you weren't monitoring would be purely based on her, how she's reacting with it, and how her pain levels, or how she's telling you that she's feeling, or a certain sensation that she has.
So burning, scar pain tends to be one of the most common ones. Reduced fetal movements.
Yeah.
So at any stage within your pregnancy, because the uterine rupture doesn't just happen during birth.
Right.
Common in birth, but it can happen at any point within pregnancy, which again is why we recommend more than an 18-month gap between pregnancies.
Yes.
Shoulder tip pain tends to be a really big implication, and it's because of the referral pathway. So the pain referral pathway, if a woman starts saying, "Oh, I've got real pain in my sort of shoulders here," that tends to be a early sign of a uterine rupture, and bleeding. Bleeding's the other one, or suddenly the contraction's stopping.
Right.
So no reason for the contraction stopping, i.e. you haven't got 20 faces that have just walked in your room.
Right, yeah.
No reason. It just suddenly the uterus stops working as effectively. And if you think about it, if part of the uterus is coming away, the uterus can't work as effectively. So if you suddenly notice that the contractions have completely stopped, that's a big warning sign as well.
God, it's so interesting. The shoulder's really interesting, isn't it? Wow.
Any woman who's had a cesarean birth before will notice that she has real bad trapped wind pain almost.
I've heard this.
Yeah, so it's the same referral pathway.
Wow. So much to learn still. I just love this so much. It's just so interesting. Okay. Okay, so cannot wait for this. Planning a home back. What if the midwife wants to transfer to hospital, but I don't?
So you don't have to get in an ambulance. As long as you retain mental capacity, you cannot be forced to do anything. However, I would be very open to discussing the reasons as to why she might be recommending an ambulance transfer. Is it because a guideline is telling her that you need to get into an ambulance to get into the hospital? Or is it because there's now meconium? Actually, you're now bleeding? Is it because there are other things? And I don't think there are very many women who plan a home back who would put their baby's lives at risk. You know, I don't know any woman who has ever turned around and said, I'm planning a home birth at all costs.
No, yeah.
We do have women who start off at home and then change their mind partway through labour because they just start, you know, not feeling confident in themselves. And we know women who plan a home birth who don't necessarily have a home birth. And this is in the first-time mum population and second-time mum population. They are more likely still to have a successful vaginal birth, even if they transfer, because they first planned to start at home, and also because they tend to transfer somewhere in the throes of labour as opposed to really early on in labour, so there's less chance of intervention and everything else. So and they know their options and choices, and
it definitely comes down to the reasoning, like you say. If it's actually this is high risk, we need to get you in, then I'm sure we would all agree it's the right thing to do.
But yes, you don't have to get in that ambulance at any stage. You know, if you think about human rights, birth rights, no, you don't. But just think very carefully
about what the reasons are. Yeah, and that will be communicated, right? It will all be communicated as to why. Okay. Right, this has kind of been answered, but why do they push for constant monitoring when not much research is there to support its use? But we know that that's just because of guidelines. It's the way it is to keep you safe. And because we don't want anything happening, but you have the choice. You have that choice. Go to the Royal College of Gynecology and Midwifery, isn't it, to check out the studies?
Yeah. So RCOG, Green Top Guideline, VBAC, and then have a look. Have a look down for the recommendations. Have a look in the C, D, A, B evidence, because there's only a handful of A and B evidence, and it's more around that Vbac is safe. And we should be using checklists and things like that. C and D evidence is further down, and then really scroll down to the bottom, have a look at the references, pull them out for the home births, the continuous monitoring, and have a look yourself.
Thank you, that's great. Okay, will it be any more painful due to the section wound and scar tissue?
No, there shouldn't be any difference. If you laboured before, though, you are more likely to have a quicker labour. So if you did labour previously, you know, spontaneously, whatever that is, then actually the labouring process should be a little bit quicker for you this time around. That's
another thing to consider, isn't it? If you've had your previous C-section came after labouring, then your body has done something huge prior to this. So actually it is likely that your labour will, it's really, really important that, because some women won't have had labour, so will be labouring for the first time. the second time round.
Absolutely.
Okay. And in that case, would her second labour be treated as a first, not treated, but would be replicating a first labour? So it could be as lengthy as a first labour.
So if you hadn't laboured before, we basically class you as a first time mum, so 0.5 centimetre an hour from 4-ish centimetres onwards. If you'd laboured before, got to sort of 9 centimetres and then something happened, then we'd probably be looking at sort of more like 1 centimetre an hour.
Okay.
As a loose guide. Actually, no, women's labours go like this. They don't go like this. So yeah.
Okay, thank you. Let's go back to anything you can do to protect your scar.
Ideally, just more than an 18-month gap between pregnancies. It's probably the best thing that you can do.
That's between pregnancies. So is that between falling pregnant or?
Yes. Yeah. Between cesarean birth and falling pregnant, that's probably the easiest thing that you can do. So leaving the 18-month gap wherever you possibly can do, and having that discussion with your consultant obstetrician as to just checking what kind of scar you had as well. Because there are different types of scar other than a lower segment, and any other sort of incision is recommended to have another cesarean as well. So if you've got like a J or an R, these are all really rare things. Again, you'd have probably been told this after your previous birth anyway. And ideally not going more than sort of 41 to 42 weeks as well is the aim. But it's your choice again. It's your choice entirely.
Can I still go into a birth pool to labour with a VBAC?
Yes, you can. So there isn't any evidence to say it's safe or unsafe, and it depends on the local unit guidelines. So it's worth a discussion antenatally again. Find out what they offer in your unit. And again, if you've got waterproof wireless monitors, you can use those in the pool. So continuous monitoring, if you want to accept something, it shouldn't be a reason not to get in the pool. But again, have that birth plan discussion antenatally to get your preferences in. Yeah,
thank you. I've been told I have the choice and feel a lot of pressure. So how do I know what's right? It's quite, it's difficult to answer, I know, because you don't know all the ins and outs. This is a good question then. Maybe this is, as a midwife, how can somebody ensure that they feel that they've got choice without feeling pressure, but still feel it's really important for them to still know the risks and the benefits to everything. So how would that discussion go? If they want to discuss their options with you, but you need to give them all of the information, what would you advise them how to approach that?
So what I tend to do is I'm a very conscientious midwife with hypnobirthing experience. So I tend to go right, but these are the benefits of what either a repeat cesarean or a VBAC. These are the risks. These are the alternatives. What does your instinct say? And then what do our guidelines say? What's the evidence surrounding our guidelines? What does the research say? Put it into your hands. I've given you all of the benefits and the risks, and that way you're making an informed decision. Now, in an ideal world, you would have that from every single healthcare professional possible. We can't actually do anything to you, whether it's taking your blood pressure, taking your urine sample, without you providing consent to us. And to provide consent, we have to provide you all of the options. I'm very aware that we're time limited within the NHS, and that's what makes it very difficult.
Sorry, I thought you meant now in the conversation. So I was like, we're fine. But in terms of in general, actually, we are very time limited overall in the NHS, and why people don't get that full informed consent is because of time constraints, and because actually you might be coming in for a 20-minute consultation with your midwife. Well, in 20 minutes, I've got a whole list of things I need to do, which are recommended overall by the package that I have to offer you as a midwife or by an obstetrician. I have a whole checklist of things I have to go through that I might not be answering your questions as you might, purely because of time constraints. I hate that. But that's the reality, isn't it?
Private healthcare might come into its own play in some respects, because actually you'll have that time with someone in the private sector a bit more because you're paying for their time. But I mean, consultant midwives will spend a whole day with you, talking through the ins and outs of these things, if you're lucky enough to have a consultant midwife in your trust. There's only about 50 in the entire country, so I know there isn't even one in the southwest, for example, at this moment in time. So then
another thing you could do, I guess, in that situation is, like you say, look at the studies, look at that involved. But there must be some books I don't even know about off the top of my head. But if you want to look into VBACs more, there must be some amazing support groups out there that you could be part of. AIMS is also great if you wanted to get some advice. You can go to AIMS as well, which I can link below. But sometimes we have to understand it does come into our own hands in the situation that we're in. We just don't have the resources to give women that care, which we know. But if we want to have all the information, sometimes we need to be going and finding it as well.
Absolutely. And two groups really recommend on Facebook. Vbac UK website, really good for lots of different types of births, you know, whether you have a repeat cesarean or Vbac, home birth, whatever. Home birth, HBAC as well on Facebook group. They're really good as well. And it's also remembering that no is a full sentence, and I don't want it to ever stop the conversation. I don't want it to be a barrier between yourself and your midwives and your doctor. But no is a full sentence. And as long as someone's provided you with all the information, risks and benefits, you know, ultimately it comes down to you. It's your decision making.
Absolutely. Could not agree more. It's really important. Okay. Will it be any more painful due to your section? Oh no, I've asked you that one. Can I refuse? I don't know if this is VBAC related, but I'll ask you. Can I refuse to be induced after 39 weeks if I haven't started labour?
Yeah,
can refuse anything.
Again, but no one can touch you with a barge pole. But again, discuss the benefits of why they're recommending it, what the risks are. I'm not going to go into induction after 39 weeks, but the Affirm trial is something that's quite flawed. It's worth looking into that and then looking into the research beforehand. And actually, I don't think I put it on my shelf, but Induction of Labour by Sarah Wickham.
Oh my God, those.
I recommend that book massively. So, you know, go to Sarah Wickham.
For loads of research. There's so much on her site, isn't there? Go to sarahwickham.com and there'll be something there for everybody to look at.
Ames does a good Inducing Labour book as well by Rachel Reed.
Why Induction Matters. And I will link these things below. So if you're watching and thinking, oh, I don't remember that, I will link it. Don't worry. I'm going to ask only a couple more because we're going to have to wrap up. But a couple of people asking how long after having a C-section should we try again, or have been advised to wait for this. Advised to wait 18 months, which is what you're saying, Angie, before you conceive again. If it happens earlier than 18 months, will I be able to still try for a VBAC? Somebody's asked.
Yeah, absolutely. It's just that the uterine rupture risk is going to increase, along with a placental embedding in the wrong place potentially as well. So that will also increase the chances of complications. It will also increase the chances of hemorrhage as well. So sometimes the other thing to think about placental embedding is sometimes it can go through the scar tissue into bladder and bowel, and other things that major complications then at that stage. So again, if you can possibly leave it that length of time, it's just going to make things a lot more simple for you. So
okay, great, thank you. Right, I'm going to ask one or two more. I'm so sorry, we'll have to do a part 2. Okay, what is your view on increased sweeps to bring on labour for a VBAC to try and reduce induction, given that the time constraints or guidance are ongoing, overdue?
Again, read Inducing Labour by Sarah Wickham. There isn't a huge amount of evidence looking into inducing labour with VBACs yet. We're still in the early days of inducing labour, because it used to be that we wouldn't induce your labour, you just have a repeat cesarean, or we'd just wait for labour. So we're still in the early days of inductions of labour methods. But a sweep is still an induction, and it's taken into consideration. It's still a method of induction. It comes with its own benefits and risks. If you wanted an induction of labour, then actually a sweep ahead of time might just do the job for you.
I was going to say, because it might limit your risk of, well, it will limit your risk of then having a medical induction later.
Potentially, yeah. So if we do 8 stretch and sweeps, it will work in one woman to reduce a medical induction. This is on first-time mums. This is based on women who haven't got a scar in their uterus. So we don't know about VBACs and stretch and sweeps. So if you were planning on having an induction, you wanted to accept that, yeah, why not try it? You know, you might as well try everything. It's the least probably risky out of all the induction processes. But if you're not planning on an induction at all, then have a look into all the risks and benefits, have a think about it, and maybe just wait until you get closer to that time to make that decision. Because I know certainly as a midwife, I said I'd never have a sweep, I'd never do anything, and I got fed up and decided
So you can't say how you're going to feel on that day, can you? You can go through 40 weeks thinking this, and then you get there and you think, so
just do it.
Yeah, as long as it's your choice, it's your choice. That's the best thing, when you know it's something you've decided and not felt pushed into. Okay, right. You know what? Last one. What are chances if the first baby is breached and kind of second? Then is there a higher risk of the second baby being breached? Do we know?
Slightly. Yeah, there is a slightly higher chance. I mean, it's less likely. So first-time mums are most likely to grow breech babies and breech position babies, but some women have heart-shaped uteruses.
Yeah.
That means you always wear a breech baby. It's what we call a bicornuate uterus.
Yeah.
And so their head almost gets jammed in
Yeah.
one sort of part of the uterus and stuff. So we're in one of the heart-shaped bits. So some women just always grow breech babies, but it is less likely in second, third, fourth trimesters than first timers.
Okay, right. Someone's just said, please part 2. I think we're going to have to wrap up. I don't want to, but I know it's been over an hour and there's been so much amazing information, Angie, and you'll have to come back on. I'd love you to. What I love is you're clearly so pro women's choices, which God, I care so much about. But being a midwife, we can get a great understanding of how to navigate that without being, you know, causing any. I don't think anyone ever wants to have any disruption with their midwife and their relationship with their midwife. We want that to stay positive all the time. That's
what we want. That's what we're trying to do. But we're stuck between a rock and a hard place half the time, and I hate that. I really hate that. But
we can do, if we can understand, women can understand more about how they can navigate, how they can do that. How can they go into an appointment getting the best out of that time, building a good relationship with their midwife. You know, all of this stuff is so important. So thank you. I can't thank you enough for giving up so much time in your annual leave as well. But for anybody who didn't get their question answered today, I really hope that you found something in that today that helped you. But head over and ask Angie on the Eco Midwife. Feel free to ask me to some of the resources we talked about and I will signpost you, and I will put things below that will be really beneficial. But my mind is buzzing because that was just amazing, Angie. Thank you so much.
Thank you so much for having me, Lucy. It's been a pleasure.
You are always welcome here. We will have to do another about so many other topics. And
absolutely.
But enjoy your annual leave and take a good rest. Thank you for being one of our midwives who look after us and give us the opportunity to have great births and VBACs. And we will speak to you soon, I'm sure. Yeah.
Speak to you soon.
All right. Thank you so much, everyone, for watching.
Bye.
Take care. Bye-bye. And I will just stay on here just for a second to say, wow, what a great conversation. I hope that you all enjoyed that. For me, I found that so amazing, so interesting. And I think, I don't know what to say. I feel a bit speechless because there was just so much information there. I think it's also, for me, so encouraging to speak to, I love speaking, all the midwives that I've had on here, all the people that I've had on here have been wonderful. But we need to remember that we always have choices. We can always discuss those, and that we have options always. And how lovely to hear about VBACs today. How lovely to hear about the statistics surrounding VBACs, about the benefits of vaginal births after C-section, vaginal births in general. And if you've got anything else you want to ask, please feel free to get in touch with either of us. And I will link below AIMS, which is a great place to go to for advice if you feel like your appointments are cut too short and you just can't get the answers you want. Some of the books that we mentioned, Induction by Sarah Wickham, and Why Induction Matters by Rachel Reed, and the Facebook or online social groups that Angie mentioned called VBACs and Homebirth After Ceaserean. I can't remember, HBACs UK. I will link them all below. And thank you for joining in today. If you know somebody who is planning a VBAC, or if you know that somebody wants to learn a bit more about VBACs, then feel free to send them this conversation and share it on your stories. And I will speak to you all next week. Next week's chat is all about homeopathy during pregnancy and for birth. So holistic healthcare with a friend and doula, Rowena, who I did my doula course with. She is a homeopathy expert and is going to discuss all of that with you next week here on my Flow Down Talk. So I shall see you there. Have a great week. If you've got anything else to ask me about, then get in touch and I'll see you all soon. Thank you so much. Bye, everyone.